Thank you so much for doing this.
All right, thanks so much for such an enthusiastic introduction. I should give these every day. It's very exciting. I'm admitting quite a few people in through the lobby as we've been talking. You'll be able to take that function over when I start sharing and giving the talk. Okay, great. So let me, you've got slides here. I'm just going to begin sharing this screen. All right, I'm going to switch to presenter mode. Okay, perfect. Fantastic. Excellent. And again, I can't thank everyone enough extending Farah's enthusiastic welcome. Actually, so far, double check. I'm seeing people in the lobby. You got it covered. Okay, great. I can't thank you enough again for your interest in this domain. And I have to say, without a doubt, REMAP has just been such a transformative effort in our fight against COVID-19. I think it's created an unprecedented opportunity to look at adaptive platform trials and collaboration across specialties and in critical care and a number of organ-specific subspecialties. And I think it's just been phenomenal what the UK has done, I think, to advance its, the REMAP mission. And so much of this, I think, vision really has obviously come to life through the hard work that so many on this call, I'm assuming, have done. So thanks very much for the privilege to meet you. And obviously, thanks broadly for your incredible effort in this fight. All right, my email is there. It's also at the end, so I'll come back to it. Watch the time, and I'll try not to talk for more than 30 minutes. Farah, please speed me up if needed. I wanted to start by just kind of a quick rapid science overview and talk a little bit about some of the mechanisms that we're targeting with the drugs here. A familiar set of drugs and the question of whether repurposing them is beneficial here. So I want to kind of comment just quickly on why we came to that idea in the first place. We'll talk about those interventions themselves. We'll talk a little bit about the inclusions, exclusions, what the criteria should be for drug cessation, the follow-up secondary events, and then I finally added an invisible bullet there that's talking a little bit about the design. It's really, I think, cool. It's seamless phase 2, phase 3, and the first in REMAP. So I wanted to talk just a little bit about that for the benefit of all. All right, so SARS-CoV-2 pathogenesis. Obviously, we've heard quite a bit about this virus binding its human host receptor, which is the ACE-2 receptor. And that might even be particularly true with some of the variants that they even have a higher affinity for that. So this ACE-2 is bound and then subsequently downregulated. And one of ACE-2's normal functions is the degradation of angiotensin II. Angiotensin II is converted to angiotensin 1-7 by ACE-2. And so loss of ACE-2 can lead...
Patrick, yes. Sorry, the slides are not moving forward at all.
Okay, thanks for the heads up on that. I see them moving forward on my screen. So let me... I must admit, I'm a little bit of a Zoomaholic rather than a Teamsaholic.
That's working now.
So, okay, so let me just, can I go do the ye old way just in the interest of keeping us on track? There are no animations, so I think we should be clear.
Okay.
All right, visible to all, hopefully?
Yeah.
That is. Okay, great. So what we're looking to do is to kind of counterbalance that loss of ACE-2, which is resulting from the viral binding to it, and the subsequent accumulation of angiotensin II. So angiotensin II has a number of pro-inflammatory, pro-thrombotic, and potentially injurious effects in the lung. We're trying to offset those with some of these repurposed antihypertensive drugs that target the RAS pathway. This is a conceptual figure that one of our domain investigators published looking at the concept that I've mentioned here, and that's that you have a loss of ACE-2 functionality because the virus binds it, and then you end up with an accumulation of angiotensin II, which promotes acute lung injury, adverse myocardial remodeling, vasoconstriction, vascular permeability, inflammation, thrombosis, a number of these potentially maladaptive effects in patients with COVID-19. Initially, there was actually some concern that chronic use of these drugs might be harmful. Early observations, and it's continued to be true, suggest that patients with a history of hypertension have worse outcomes when hospitalized or diagnosed with COVID-19. So there was a concern that maybe the chronic use of RAS inhibitors, ACE inhibitors, and angiotensin receptor blockers, or ARBs, could lead to an upregulation of ACE-2. So that people actually had potentially more ACE-2 floating around, and that might cause the virus to have more pathways into the host. Those societies were very quick to kind of dismiss that concern, and the data has really supported that. And in the process of the data reassuring us that it's safe to give these drugs in patients with COVID-19, it actually showed a number of potentially beneficial signals that got us excited about this intervention. So I'll just zoom a little quickly here on the left-hand side. This is a meta-analysis now looking at a number of observational studies in people that are using ACE inhibitors or ARBs to treat hypertension or for other indications such as diabetes, post-myocardial infarction, et cetera, and showing that there's actually a reduction in the adjusted odds of death in patients that were receiving those drugs in the meta-analysis as shown here. So not only did they appear to be safe, they actually look like they may be associated with some benefit. Now, again, it's a little bit of a different context than we're looking at in the trial. These are people already on the drugs, continuing them now, whereas in the trial, obviously, we're looking to start them de novo. But overall, I think a very reassuring safety signal for these drugs and also some enthusiasm that they may be of benefit. This is now the results of the BRACE Corona trial. This was a trial that actually tested the hypothesis about whether it was safe to continue or whether you needed to discontinue these ACE inhibitors or ARBs once you're diagnosed with COVID-19. This was published in JAMA in January. And not only was it safe, there was a number of trends in a smaller study, but towards benefit. So there was a trend potentially towards more days alive outside of the hospital. That's shown here with a odds ratio on the lower side of 1, and then these are indicative of benefit if the odds ratio is on the positive side of 1. Is now showing beneficial effects, potentially a reduction in COVID progression here, reduction in myocardial infarction, number of other potential. So not only did the interventions appear safe, at least when used chronically and continued in this setting, but they also appeared that there may be some benefit. I want to take a conceptual sidestep very quickly and touch on what Farah mentioned about the CCR2 target here. Now, again, this is not available yet in the UK, but I'll mention it very briefly just because if it does become an option, I think there might be some really exciting opportunities here to improve outcomes. So CCR2 now is looking more at blocking inflammatory responses to COVID. So it is the protein that mediates the attraction of macrophages to injured parts of the lung. And these macrophages are the ones that produce a lot of the cytokines that we're used to hearing about targeting. And obviously your incredible work has shown, for example, reductions in IL-6 through monoclonal antibodies could potentially, can, from the trial, of course, benefit patients with COVID-19. We are looking at this hypothesis now even a little more proximally with this idea now showing maybe if you block the cells that produce these cytokines from even getting to the lungs in the first place, you may actually improve lung inflammation. And there was, I think, a number of exciting signals, but perhaps this is the most exciting one. This is also UK data, genome-wide association study looking at COVID severity. And as you can see, CCR2 in a couple of different approaches to looking at it does stand out as one of the potential genes associated with severity of illness in patients with COVID-19. So why are we talking about it in this domain? There's data that the particular CCR2 inhibitor that we've chosen to study will interact with, in a synergistic way, with concomitant blockade of the AT1 receptor, which is what's targeted by the ARB. So in some patients, if this domain, when this domain becomes available, if it does in the UK, they could be randomized to receive both an ACE inhibitor, an ARB, and then an ARB plus this investigational new drug, this IMP DMX-200, which is an oral inhibitor of CCR2. Again, a very exciting stuff. It's not available in the UK quite yet, so I don't want to spend too much time on it, but it'll be a privilege to kind of come back and talk more about that if that ends up being relevant. So overall, the domain looks at modifying the what we think is a maladaptive derangement in the renin-angiotensin system that results from COVID-19. It'll enroll patients in both the moderate and severe state, as far as mentioned, obviously, that they'll be in the ICU, but they, of course, could still meet criteria for either moderate or severe, I presume. It's designed as a seamless phase 2, phase 3 design. If I'm not mistaken, that may be the first time we've used this design in REMAP, and I'll talk a little bit about that at the end, but essentially it'll use a stop-go rule applied based on the initial efficacy signals that are looked at by the Statistical Analysis Committee and the DSMB, and then a decision will be made to continue on to phase 3 if there is evidence of early efficacy as well as safety is in place. So the inclusion criteria, starting with probably a familiar set of them for the overall trial, these are patients just with suspected or proven COVID-19. The domains are only available to those with suspected or proven COVID-19. Again, it's both moderate and severe patients can be enrolled. Now, the domain-specific exclusion, we'll spend a little time on this slide. In the moderate state, more than 96 hours can't have elapsed since hospital admission, and in the severe state, more than 48 hours can't have elapsed since ICU admission. And there are a couple of qualifiers here just about when their state transition may have taken place and how you should set the clock depending on that. The concept, and there's another one on the next slide that I'll mention, the concept behind these time periods is just that we think this intervention is likely to work very early on. Later in the disease course, for when organ failure sets in, we think these drugs may be challenging to give. We think they're less likely to be effective at that point. The spiral of disease reflects more the organ failure and the secondary effects of the infection and its consequences, perhaps, and not so much this kind of early interaction with the host. So we do want patients kind of early in their course, and it may very well be that the drug just doesn't work quite as well later. So that's why those are included here. There is a little bit of nuance, and happy to take any questions on interpreting that at the end if that's relevant. Patients that are already receiving these drugs or similar drugs, they're not commonly used, but direct RET inhibitors are also an exclusion for this. An RNA, an angiotensin receptor neprilysin inhibitor, would also be an exclusion because that includes essentially an ARB, or a chemokine receptor modulator also would be an exclusion if they're already receiving that. If they were on it before, prior to the hospital admission, they should also be excluded. Again, we think that the drugs may chronically change the receptor milieu a little bit. We really are looking for people that are having a fresh start here. The subject of discontinuation, as I say, is studied elsewhere. If they have a hypersensitivity to these drugs, ACE inhibitors or ARBs, that's an exclusion. I want to pause quickly on angioedema. Angioedema in the setting of prior RAS inhibitor use is certainly an exclusion for the trial, but really any angioedema should be an exclusion, including hereditary angioedema. There's data that patients with a hereditary angioedema history may have a higher risk of ACE inhibitor-induced angioedema, and so we should stay away from all patients that have a history of angioedema. So it's important to emphasize it's not just related to the drugs, but it's really any history. These are this next bullet point is probably where most of the conclusions will actually take place. So if the clinician believes that administration of an ACE inhibitor or an ARB is inappropriate, there's two main concerns that we have. One is the risk of clinically relevant hypotension. What could that mean in moderate patients? Well, we've written it very generally, very pragmatically. We certainly do have a sense that these are obviously repurposing commonly used drugs. We want to make sure that we allow clinicians adequate latitude and discretion at the bedside to make a decision as to whether they think it's a reasonable setting to start these drugs or not. Generally speaking, the kinds of things that make me uncomfortable to start these drugs are if the patient has signs of dehydration. There can be more of a first pass hypotensive effect in a dehydrated patient. We will sometimes even hold the diuretic for a day or so before. We'll make sure that they're adequately hydrated. That's an important consideration that I in my practice spend a lot of time thinking about. Aortic stenosis or hypertrophic obstructive cardiomyopathy are conventionally thought of as contraindications to these drugs. However, there's some nuance there, but I would generally plan to stay away from those drugs in patients with those conditions. And then people in whom their blood pressure is already marginal. Again, this is largely in the moderate state. These are people not on vasopressors for perhaps. I would be careful in someone with a blood pressure less than 100. I might try it in a patient with a blood pressure between 100 and 120. And we frequently do for patients with hyperfiltration injury, diabetic nephropathy, post-myocardial infarction, heart failure, et cetera. But less than 100, I start to think that they may not have a lot of reserve to tolerate the drug. So those are generally some of the criteria that I use. Again, these are offered as an example. Really at the bedside is where this decision should be made. Now, if someone's already taking vasopressors, they can be enrolled in the domain and they can receive the interventions. These drugs at a low dose have a very modest effect on hypertension. Again, that first dose effect might be more pronounced, especially in the setting of dehydration, so something to watch for. But generally speaking, a low dose may be tolerated. However, we leave it to the clinician. I think if someone is on a relatively low dose of vasopressor, it may not be unreasonable to try this. In contrast, if they're already on a moderate to high dose and there's concern that adding these drugs might cause an escalation of doses, go from moderate to high to already very high, or the initiation of new vasopressors, that's probably not a stable enough situation to start these drugs, in my kind of opinion. But again, this is really left to the clinician at the bedside. To some extent, when we wrote the domain, we conceptualized this a little bit like the effects of sedation in the ICU, where we think that it, of course, provides an important benefit, but it also is comes at some expense with a hemodynamic effect. And when someone's on a little bit of vasopressor and they end up on a little bit more, that might be worth it. And someone that is already unstable, those are obviously tougher decisions, and we might recommend that patient wouldn't be relevant here. It's tough to know, but we certainly have also thought a little bit that this is kind of akin to the beta blocker approach that's been trialed in septic shock. Obviously, in some of those smaller trials, there was even a reduction in the subsequent exposure to vasopressors with the beta blockers because there are a number of potential other benefits to targeting the disease early on and improving kind of outcomes before organ failure sets in and drives a lot of the shock. So We obviously don't have a lot of experience with these drugs. That's why it's designed as a phase 2, phase 3. But those are some of the criteria that I might conceptualize practically at the bedside to try to interpret that first very broadly worded pragmatic criteria. Similarly for hyperkalemia, there is no cutoff. For example, has only been added to these slides. It's not in the actual DSA. Similarly for the hypertension considerations. The 5 milliequivalents per liter cutoff is what I use in my practice. If it's up to 5, I'm comfortable starting it. If it's more than 5, I hesitate. So you may consider it as well, but again, it's up to the clinician at the bedside. Hyperkalemia needs to interpret, obviously, what we think their trajectory of renal function is. If someone's has oliguria and has rising creatinine, if the potassium is 4.8, I probably wouldn't give these drugs because it looks like they're heading on a trajectory towards worsening renal injury. That's going to make these the drugs more challenging, obviously, but also the potassium considerations more of an issue. So I'm happy to take questions and discussion both at the end of the webinar and also as this consideration comes up at the bedside. The patients with known renal artery stenosis also will have an exclusion for that. These drugs are contraindicated in pregnancy and should not, I think, broadly be used in breastfeeding. So that's left to the discretion of the clinician how they want to assure that the patient is not pregnant, if that requires a pregnancy test or not. We didn't articulate it in this pragmatic domain, but that's left up to the clinician to decide, assure themselves that there's no concern for suspicion for pregnancy. Renal impairment, if the creatinine clearance is less than 30, or if the patient's on dialysis, they should not be enrolled. And enrollment into trials looking at these drugs, of course, also should preclude them from being studied in this one. If the domain is available in a moderate state, and the patient was assessed for it in that state, now they're being assessed in the severe state, they should not be included. This criteria is a little ectopic in the sense it probably belongs with the first 2. This was also intended to reflect the concept that we want to look at patients early in their disease course. If they screen failed for moderate and you're looking again a couple days later in severe, it's just probably not someone that we're thinking is going to benefit early on. Happy to take questions on that. I know it's a little bit of a nuance, I guess. And finally, of course, if the treating clinician believes participation is not relevant or not in the patient's best interest, then that patient should not be enrolled. For DMX-200, we can spend more time on it if it's relevant later. The considerations largely relate to acute and chronic liver disease. So the interventions themselves, patients are randomized to either receiving an ACE inhibitor, an ARB, or in some settings, a combination of an ARB plus DMX-200, or nothing. It's an open label, no placebo, but no RAS inhibitor intervention. The treatment duration is 10 days or until hospital discharge. As I mentioned, it's open label. We designed it intentionally open label, obviously for pragmatic purposes, but also because we wanted to, we felt like it was going to be very difficult to blind a study with dose titration, and the hemodynamic effects may be apparent to clinicians that blinding could be very challenging. So it's the reason it is for that, and is studied in that way. So for the RAS inhibitor arm, again, it's a pragmatic domain, and so there's several agents that are permitted. What we've asked is that sites pre-specify which agents they would like to choose, and we've asked them to specify 2, a first choice and a backup choice. We've asked that this be done to kind of, as much as we can, assure some degree of consistency in the interventions being provided. We don't want too much patient-by-patient decision-making on which interventions are going to be applied. We'd like as much as possible for there to be consistency. We've also provided a hierarchy for what we would prefer that the choices be, again, to try and just standardize the agents that the patients are getting for the purposes of the trial, but still allow pragmatic flexibility given that drug availability might vary regionally. Clinician familiarity with the drugs might also vary. So the hierarchy is included here. Again, if ramipril and lisinopril are the 2 most familiar and accessible drugs at a particular site, we'd be thrilled. If it's enalapril and trinalopril, that's okay too. Feel free to pick whatever's most available and familiar for your site, and then to indicate a backup option as well. The backup option should only be given in the event that the first option is unavailable. So if lisinopril is chosen and lisinopril is found not to be available at some point, there's drug supply limitations, okay at that point to go to the second choice, but otherwise we'd prefer to start with the first choice and stay there if you can. These are the lists. This is also available, of course, in the DSA. And we provide an example dosing schedule. We've gotten some phenomenal questions already about how the drugs should be delivered and dosed in this setting. And it's challenging because there's a lot of patient-by-patient considerations. We've touched on the hemodynamic considerations. Of course, there's also renal function, which we've talked about, potassium, which we've talked about. So really important to sort of think just within the patient. We've provided the dosing table, which is in the DSA. We developed it largely for moderate patients with the thought that these numbers would be relevant to patients not receiving vasopressors that had what we thought was a reasonable hemodynamic reserve. I think the doses here are now provided again with a starting dose if their blood pressure was less than systolic 120. Again, I would hesitate to enroll a patient if their systolic was less than 100 to begin with, but that's a pragmatic interpretation that's left to the clinician. There's a dose provided here. There's a slightly higher dose provided if they're at a bit more hemodynamic room. And then there's a titration suggestion such that if the dose is, if there's clinician concern that giving the drug will cause clinically relevant hypotension, defined as the need for significant escalation of care, initiation of a new vasopressor, initiation of a vasopressor if it wasn't required, et cetera, then that should be something that should prompt the dose to be held. If blood pressure is between 95 and 105, I generally would think that dose might be a bit too high. I would decrease the dose a little bit and see if you can do this. I should say, sorry, this is being done kind of on a day-by-day, every 1 to 2 days basis, depending on the timing of the drug administration. If the blood pressure is between 105 and 120, I'd keep that dose. I think that's right where they should be. And if there's a bit more room, more than 120, say to 130, you might consider going up, titrating the dose. So this is, I think, again, an example titration table. We largely intended it to be in moderate patients. It is not a required study titration protocol. It really is up to the clinician at the bedside. As I say, in patients receiving vasopressors, they can receive these drugs. It's really based on physician judgment at that point, accepting the use of vasopressors might be increased, but that might come at the potential benefit that these drugs could offer. Again, if you think it's safe to try a low dose and to potentially gently titrate, we think that might be reasonable, but it's really up to clinicians. And again, there will be an efficacy assessment, a safety assessment, as well as the efficacy assessment in phase 2 before graduating to phase 3. Titration of blood pressure. Why did we do it this way? These are some of the early reports, or an example of one of the early reports that showed a striking relationship between blood pressure and clinical outcomes. So patients with worse clinical outcomes tended to have higher, in this case, mean arterial blood pressure. And here you can see a strong correlation between the mean arterial blood pressure and the AA gradient, indicative of the degree of parenchymal lung injury from the infection. So we really are essentially in the domain, and at least people not on vasopressors, presuming, or I suppose, proposing rather to use the blood pressure as a personalized readout of excess angiotensin II activity and to titrate the drugs against that blood pressure in a way that is basically using it as a surrogate for the degree of excessive angiotensin II activity and the potential for lung injury as a result. So it's a little bit of a personalized medicine way. The blood pressure is acting as a proxy for the degree of potential lung injury and excessive angiotensin II activity. Again, in patients without receiving vasopressors, obviously it's a different consideration of that group. So patient, if there's physician concern, rather that administration of the ACE inhibitor at any time, or the ARB at any time, may result in clinically relevant hypotension associated with increased risk for death or needing significant escalation of care, the drug should be held. That's, I think, quite clearly emphasized in it. Obviously, I'm sure will be practically, will make a lot of sense. Regarding the potential for hypotension and the resultant potential for the need for vasopressors, we hypothesized that there could be treatment-related increases in vasopressors, particularly in severe patients, obviously, that are receiving them already, but that this may be offset by other benefits. Again, though, I think it really is just a clinician discretion consideration. How stable is the patient? Are they in a position where they can try a little bit of a low dose of one of these drugs and then a gradual, gentle up titration? Again, really something that'll have to just be kind of individualized at the bedside, and with clinician comfort, obviously, being the most important variable. The CCR2 inhibitor, I won't spend too much time on. Suffice to say that it's a fixed dose, doesn't require titration, and is administered as capsules that can be crushed. In the control arm, now patients in the control arm, as I mentioned, don't receive a placebo. They shouldn't receive any ACE inhibitors or ARBs. If they do develop hypertension, the need is to, or the preference, sorry, is to provide a non-ACE inhibitor, non-ARB intervention, calcium channel blocker or beta blocker or whatever is thought to be clinically appropriate. If they do need an ACE inhibitor or an ARB, it's okay. We'll count it as a crossover. But if they develop an indication, myocardial infarction, heart failure, it's an established indication, we shouldn't hold it back from them in that setting if they can tolerate it. it's okay to cross them over, and we've obviously just noted that. The hospital, the kind of daily data does actually collect the particular agent that they got in the particular dose, so we'll be able to watch that very closely. But again, the preference is not to, but if it's needed, they can cross over. Drug cessation. So for ACE inhibitors in the ARBs, hyperkalemia should prompt cessation of the drug. So I think generally if the potassium is more than 5.5, the drug should be held. This is important, though, that it's interpreted in the context of renal function, which can be both the creatinine as well as obviously urine output. Of course, the serum creatinine may lag a little bit. Oliguria may precede a rise in creatinine and a drop in the kind of clinical chemistry indicators rather of renal dysfunction. So it's important if patients look like they're on a deteriorating trajectory of renal injury, that 5.5 may be too high. You might even need to stop earlier if it looks like it's the case. Similarly, if they have primary renal impairment, if the GFR is now dropped below 15, or there's been a deterioration in renal function, such as a 50% increase in creatinine over 48 hours, that's a patient that should stop. These drugs can cause hyperkalemia, but they also can cause renal impairment. Initiation of dialysis also prompt holding these drugs. I will say that a small increase in creatinine is expected. These drugs actually do cause preferential vasodilatation of the efferent renal arteriole. In other words, they decrease the glomerular filtration pressure. So they actually will potentially cause a little bit of an increase in the creatinine and a little bit of a bump in the GFR. In reality, though, we're not looking for those small changes. We're accepting that those occur. You'll see in the secondary endpoints, it's really only stage 2, 3, et cetera, of renal impairment that we start to get worried about. If there's been exposure to other nephrotoxic agents, IV iodinated contrast, other drugs, you may consider that may be too much potential nephrotoxic injury for the patient. Perhaps you should hold the dose and allow the creatinine to declare itself. Clinically relevant hypotension, we spent a while talking about. It's really worded pragmatically, physician perceived risk of death or significant need for escalation. So we've left a lot of discretion and latitude to the bedside. Of course, angioedema should prompt ACE inhibitors to be held. Again, I wanted to mention that, which we did. Hypotension, if there's clinician concern that the drugs are going to cause the potential increased risk for clinical escalation of care, then obviously they should be held. And again, I'll emphasize that point that we do acknowledge that some patients with vasopressors could be trialed on the doses, low doses initially, and then potentially titrated. It's really at the clinician kind of discretion whether they think it's safe to potentially proceed with that, and we'll see if it works. Comment on hyperkalemia I want to make. Just one of the other observations that led us to this hypothesis that early on it actually was observed that patients presented more frequently with hypokalemia, and that severe hyperkalemia was actually quite an uncommon phenomenon. The degree of hypokalemia is also associated with lymphocyte count here, C-reactive protein, et cetera. Again, that concept that we are trying to modify what we think is a deranged renin-angiotensin activity pathway, and these are some of the surrogates that suggest both hyperkalemia should be uncommon, which is potentially reassuring, but also that this pathway may be relevant in this disease. We mentioned that we were only going to focus on stage 2 and stage 3 renal impairment because a small bump in creatinine is potentially expected. So that's important to emphasize. The definitions here will collect this data on the discharge form. And then if there's a change in the baseline to peak creatinine, obviously we will check that. We will follow the number of times that patients get angioedema in all of the arms, so that obviously there can be a comparison of the ACE inhibitor to other arms. We will look at liver function. We'd like this to be checked as much as possible in all patients because we, of course, will use the non-CCR2 inhibitor arms as the comparator arms for the degree of biochemical dysregulation, these hepatocellular transaminitis markers. But we understand that it may be practically challenging in some settings, and there's a little bit of latitude to check this. These are really being checked for the CCR2 inhibitor, and again, to allow us to have a comparator event rate. Practically, what we would like is that if it's possible, if they've been checked between days 1 and 5, 6 and 10, and 11 and 14 once clinically, it's perfect to use those numbers. Just provide those numbers in the CRF, taking the highest numbers possible if there's more than one. If they haven't been checked and it's possible to have them checked, I think that would be a preference too. But again, if that's problematic, it's understood that may not be feasible in all patients, and that's okay. Again, DMX-200 is a little bit more to talk about with SUSARs, but we'll come back to that later if that becomes relevant. And then, of course, severe adverse events is defined in the protocol or collected. Safety events, hypotensive episodes. You'll see in the CRF a question about this. It's asked on discharge, did the patient have more than one or more hypertensive episodes that were clinically relevant while they're admitted to a ward? This may not be a question that's answered often, I guess, if this is predominantly enrolling in the ICU. Far could comment, but what we were looking for there, if it's germane, is hypotensive events requiring, rapid response team, fluid administration more than 500 cc's, ICU admission, vasopressors, these kinds of things, clinically relevant hypertension. We will look at vasopressor and renal replacement-free days, of course, as part of the primary protocol. And then, as I mentioned, we will be tracking the drug doses administered to be able to look at adherence. I'll go quickly past the CCR2 inhibitor, come back if it's relevant. Again, tolerability and adherence. I'll emphasize a few points. It's a pragmatic trial. Dose and titration should be determined at the bedside by the clinician and the investigator, and we're happy to, upfront think about some of the approaches to that. But we felt it was hard to standardize a specific recommendation framework for dosing and titration with the number of nuances that are relevant in this setting. Design is seamless phase 2, phase 3. Again, may reassure investigators and patients to know that there is an initial evaluative period in phase 2 before a larger sample size is enrolled that looks at tolerability and safety. And we have asked that all the drug doses are documented during the study window, at least, so that we can follow whether patients were able to get on what doses they were able to get on, I should say. So for follow-up, it's the obviously primary outcome that we're all familiar with, some of the secondaries that I mentioned there. And these are, again, articulated here for the completeness. All right, just 2 minutes quickly on the design. It's great. It's seamless phase 2, phase 3. So it looks initially at organ support-free days, of course, the primary endpoint in REMAP. And then it makes graduation decisions separately in moderate and severely ill patients. It doesn't use nesting and it doesn't use RIR in phase 2 at least. And so it does this initial phase 2 period, looking at the primary endpoint. It asks whether there's been more than a 20% improvement in a reduction in organ support-free days, whether the probability of that occurring is greater than 50%. If the patient sample size hits 300 for the ACE inhibitor or the ERB, and we have not achieved evidence that there's more than 50% chance of a 20% improvement in outcomes, we'll stop, and it'll stop at phase 2. DMX-200, it's a bit of a stricter bar to graduate, and the comparator is against the active comparator in the ARB arm, but we'll talk more about that later. And then a lot of text here just emphasizing again that it's not just a decision based on efficacy, it's a decision based on safety as to which interventions graduate or not. And the DSMB will look very closely at the data to make that determination. Some or all of the interventions may graduate, so it's conceivable that the ACE inhibitor may be dropped, the ARB may continue. That scenario is a possibility. If they are continued, then all of the patients enrolled in the phase 2 will count towards the phase 3 evaluative period. We won't know that there was a transition from phase 2 to phase 3. It's seamless. And so the patients that contributed during phase 2 will just be part of the analysis population for the phase 3. So in other words, a running start on looking at the primary outcome in the larger population, if we get to that point. The last slide has my email. I also want to just comment briefly that we were really fortunate in this domain to have a number of incredible collaborators. Tony Gordon really leading a lot of the providing a lot of thought leadership, I guess, in the domain, and also championing a number of potentially interesting additional interventions in the domain that we won't say much about at this stage, but all that to say there might be more exciting options coming for participants that are interested in the science. So my email is here, Far has it. I'd really encourage any questions, comments, thoughts, very available and excited to help. And once again, I can't thank you enough for your support and interest in the domain. It's really a privilege to have the chance to collaborate with such a great group of investigators. Turn it back to you, Farah. Thanks.
Thank you, Patrick. That was a brilliant talk. Thank you so much. Very clear. And I think you've actually answered a few questions that have come up in the chat, but I will just go through them with you now just to clarify anything anyone has. So let me just scroll up. So I know, Patrick, I've sent you an email before from one of our lovely Welsh sites that have had queries regarding titration and dosing in relation to blood pressure. And so one of the questions here is, I'm interested in how we manage hypertensive patients at the end of the 10-day period. It's not uncommon to see hypertension that needs treating. Would we institute a new agent in anticipation of the ACE inhibitors or the ARB discontinuing?
What a fantastic question. It's a great question that's come up in our discussions too. So I have to say, this does come up. So this is great. You know, one of the, I won't say regrets, but one of the hesitations that we kind of had initially, the 10-day course was chosen because a lot of the dexamethasone, a lot of the other interventions were being looked at for that short period of time. And they had the idea that patients would recover from their infection or they wouldn't. This was months ago. It's now clear that this vascular injury and the derangements and host physiology last for a while. So although I can't recommend it, or I won't recommend it, I guess, as part of the domain intervention because it stops at 10 days, it's up to the clinician. I would think generally if a patient's on these drugs, their blood pressure's at target, they're doing well, there's no renal issues, very reasonable to continue these drugs, and that there possibly could be some benefit. Again, provided not as specific guidance, but general thought on this question.
Jeremy, I think that covers your question as well. I would also like to add that this is, I mean, you guys know, this is a pragmatic trial. We do try and leave everything as much as possible up to the treating clinician's decision. So if you need to up titrate, down titrate, that's fine. It's not a protocol deviation. If the patient moves, even though we stipulate that the intervention is 10 days or until hospital discharge, if you cannot, because I know how super busy everyone is, if you can't provide the intervention when the patient moves to the ward and they've only been on ICU for 5 days, that is not a protocol deviation. We capture the doses given, we're able to collect the data and analyze it. So it is not a protocol deviation if you need to change or stop or halt these interventions. I will also add, as you guys know, when I've been nagging you about completing the domain choice pages, you have to choose your first choice. A lot of you have given me your second choices, but when it comes to adding, updating spiral, I can only add one drug for each group at a time. So as long as we have your first choice, if for some reason the cupboard is bare, we can change it. We do not want you swapping between 2 drugs. I know Patrick did say that. Okay, let's see. So we had a question regarding a lot of the medication is, so we specific oral, administering it orally, but of course, NG and enteral is fine. We're very happy with you crushing the tablets and popping them down the NG tubes. See, we have another question. So Jeremy did ask whether it's okay to continue after 10 days. And he specifically said, is there a rationale for not continuing intervention after 10 days? But I think you answered that.
Jeremy, I think you read our mind perfectly. Very, very good question.
And I know our sites really like when we provide dosing tables, guidance, and we have done that. But of course, it is just guidelines. So if you, I know some of you have provided us with what your local site plans to do, and that's perfectly fine. As long as it fits between our parameters, then I think that's perfectly fine. But you can always provide us with any more questions. I can either chase Patrick or we can get back to you as soon as possible.
Yes, I'd echo that point too. We'd be happy to look at local protocols or, you know, strategies developed and discuss them, you know, prior to implementation. Absolutely.
I'll give people a few more minutes to ask any questions. Patrick, do you have anything you want to raise? Any common things that you've noticed have come up?
Great question. No, I think we're really excited to get more experience. A lot of the enrollment so far has been in the Netherlands, and the domain is close to live in a number of different settings. So as investigators get experience, we'd welcome any general thoughts, questions, comments. You know, a pragmatic domain, and the only way that we can sort of learn, you know, kind of how things are going, but not obviously know too much about how things are going, but is generally to sort of have an opportunity to get your questions and feedback as they come through. So please don't hesitate to ask us general questions. 100%.
And for our sites, I know my sites love to ask questions. So if I get questions from you guys that come up repeatedly, I will be adding them to our FAQ and obviously feeding that back to you on a regular basis. I know I give you guys regular updates, so they will come up. We have another question here. Can you expand a bit more on UK? Okay, so when it comes to moderate versus severe, so for the study as a whole, severe patients are ICU patients on organ support, and we're purely talking about pandemic patients here, right? So ICU patients on organ support. Moderate patients would be ICU patients not yet on organ support or not in ICU, so ward-based patients. Now in the UK, we do not have the ACE-2 RAS domain open in our non-ICU patients. So you can randomize ICU patients to the ACE-2 RAS domain, whether they're on organ support or before they get started on organ support. As Patrick said, we do want to get these patients in as early as possible. And that's why we can have ICU patients that are not yet on organ support recruited to the RAS domain. Again, I know I probably say this quite a lot, but we have various interventions in this domain. And you don't need to take part in every single intervention to have it set up at your site. You need to have at least 2 interventions to set it up at your site. And this includes no ACE or RAS intervention. I know a lot of you are interested in getting involved in the DMX-200, but as that is not yet available in the UK, you can of course get started with all the other interventions while we get the drug ready for shipment out to your sites in the coming weeks or months, however long that takes. I don't have any timelines as of yet. We're going to have some meetings this week, but as soon as I know, I will let you know. But please do, if you're interested in starting any of the interventions, get those choice pages back to me. We can get you activated.
And that's a great comment, Farah. And I would emphasize too that that domain, the CCR2 inhibitor is given in conjunction with the ARB. So the ARB data is both needed as an active comparator, obviously, but also the approach to the ARB titration, the dosing, et cetera, will all be information that can be carried forward when you do launch the DMX-200 intervention. So, certainly would be worth considering.
Patrick, correct me if I'm wrong, because I have had this question from sites. Some sites have said, are we not going to get the DMX-200 intervention alone, rather than with the ARB?
It's a great question. So phenomenal question. It might seem a little out of place to be talking about a CCR2 immune modulator in a RAS domain, but it really was that observation that there is synergy between this target, this particular drug, and ARBs. And so all of the work that the company providing the DMX-200 has done has been in combination with the ARB. They've studied this mainly in inflammatory nephropathy, FSGS, and diabetic nephropathy. And they've looked at it in combination with ARB. And there's a lot of mechanistic data, and there's also the clinical observations that there's probably a synergistic effect that occurs when both interventions are given together. So it's a great question. There is no DMX-200 alone intervention. It's always with the ARB. I will say, if we get to that point, we can talk in more detail, but if the patient needs to stop at ARB because they develop any of the criteria we've outlined, they can continue DMX-200 and stop the ARB once they've been enrolled. But at least from the beginning of it, everybody has to get both in that intervention. Great question.
That's great to know. Thank you so much. I will give people another minute to get any questions in. I don't see any little hands up, no hands raised. If we have no more questions coming in the next few seconds, Patrick, I would just like to thank you so much for a really great presentation. This again has been taped, so it will be made available on the ICNARC website. I will be sending around an email to let you all know when it's been downloaded, and is available for you to download it to your local trust computers if that is what you wish to do. And it will be made available for all of our global teams. I'd like to remind you all, while I have you on here, that if you do ever require any up-to-date UK documentation, all of it is on the ICNARC website. It's not on the global REMAP-CAP because I have no control of that website, and we all know I like control. So everything on the ICNARC website is where all the UK stuff is. We have no more questions. Patrick, thank you so much for taking your time to do this presentation.
Thank you.
We're giving everyone back 10 whole minutes to have a cup of tea. So thank you all for joining. I hope you have a lovely rest of your day and week. Thank you all very much.
Thank you so much.
Bye-bye.
Bye-bye.